MashaAllah, I think the numbers are amazing. And I think it's probably we could start maybe another minute for people to join. Assalamu alaikum. Good evening, everyone. It's a pleasure being with you here today with my dear friend and colleague, Professor Kamal Al who's well known to all of you, Professor of Medicine and Cardiology at King Abdulaziz University, and to myself, Walid Al Habib, I'm a cardiologist at King Saud University and Al Habib Medical Group. Uh, Today's topic, I believe, is very interesting, not something that we usually talk about as cardiologists. Um, Not undermining its importance. There is no doubt that it has been important for a long time. Maybe we, as heart failure cardiologists, have noticed and realized its importance earlier than other cardiologists, incorporating it into our guidelines because we know how much infection affects the heart failure progress and worsening and recurrent hospitalizations. As you will all probably recall, in the Saudi Heart Association Heart Failure Guidelines since 2019 and updated in 23, have recommended clearly the need of influenza and pneumococcal vaccines. Nevertheless, our cardiac patients are older, they have comorbidities, and all sort of infections actually worsen their progress and increase their morbidity and mortality. And I think the very two important topics that we're going to be discussing today, uh, me and Professor Kamal, are quite interesting. And one of the main reasons we are discussing them is because we can prevent them. We do have vaccines to prevent these infections. So I believe they are very important to be discussed. And through this, I do actually thank GSK for sponsoring and supporting such events to increase the awareness of healthcare professionals, including cardiologists, in providing such care to our patients. The discussion can be long. Who should provide it to the patient? Is it the cardiologist? Is it the cardiac clinic? Or is it the vaccine clinic, the family medicine? At the end of the day, if we're all aware of the importance of these vaccinations, we can at least recommend it for our patients and make sure they received it during their follow-ups and get the care that they deserve. Um, Without further ado, I would like to start with my part. Um, Let me see if I can share screen. Am I shared? I'm unsure. Excellent. This is just a disclaimer. Um, Shingles, unmasking a silent threat for patients with cardiovascular disease. Now, the story of shingles uh, with age, more than 90% of adults at the age of 50 or more are infected with varicella zoster virus and are at risk for shingles. We mostly get what people call chickenpox in childhood. And then with age, the reactivation is what happens. Up to 1 in 3 people will develop shingles in their lifetime due to varicella zoster virus reactivation. The incident rates are similar between countries, overall 6 to 8 per 1,000 persons years at age of 60. Each year, there are an estimated 1 million new cases of shingles in the US, for example, 1.7 million in Europe, and 1.5 in China. The elderly population above age 50 constitutes, as you know, more than 45% in Saudi Arabia that are subject to this disease. Now, why do we get reactivation? It's simply because of the age-related decline in immunity, which is the dominant driver of shingles. And in childhood, we get the primary infection, which is, as I said, chickenpox. And then it goes into a dormant phase through cellular immunity. But then, as we grow older, our specific varicella zoster specific cellular immunity declines. And in this decline, we get the reactivation and an increased risk of shingles. Now, as you can see in this chart, the incidence per 100,000 persons per year increases significantly, shingles specifically with age more than 50. And the problem is not just the reactivation, it's the complications of the disease. If it was only some skin disease or rash like it happens usually in childhood, it wouldn't be a big problem. But the complications, which I'll touch on very soon, and one of the major ones, one of the most famous ones, is post-herpetic neuralgia, very severe pain that again increases with the age of the patients involved. Now, many cardiovascular conditions impact the immune system, as you all know. Our cardiac patients, whether it's because of their age or because of their comorbidities, they have a decrease in their immunity and increased susceptibility. And there is growing evidence suggesting that immune system dysregulation, inflammatory pathways, may have a critical role in cardiovascular conditions, whether it's atherosclerosis, MI, pericardial disease, heart failure, hypertension, rhythm disorders. In an acute cardiovascular event accelerates immunosynthesis with increased proportion of CD4, CD28, and reduces your immunity within 1 year. Adult patients with cardiovascular conditions may be at increased risk of developing shingles in comparison with the normal people, with an estimation that was found in some studies to reach 34% increased relative risk of developing shingles in patients with cardiovascular disease. With shingles, you have a 78% increased risk of stroke within 1 month of herpes zoster, 25% risk of MI after 1 month of involvement, 22% risk of arrhythmias within 2 years, and 14% risk of coronary artery disease within 2 years. Most of the studies indicate that the risk of cardiovascular events is the highest during the first few weeks post herpes zoster and decreases over time. So shingles, as we mentioned, is a reactivation after you get the primary infection and you go into a latency phase. You get it goes to the dorsal root ganglia, and with depressed immunity, you get reactivation. The acute presentation, many of you have probably seen and know, is just the rash, unilateral. Those who speak Arabic, we call it al-hizam al-nari. It's like a belt, unilateral vesicular rash. The pain can be excruciating, often described as aching, burning, stabbing, or shock-like. As I said, the problem is the complications. Post-herpetic neuralgia, neuropathic pain persists for months. Herpes zoster ophthalmicus affects 25% of patients with shingles and may lead to vision loss in rare cases. Other complications: scarring, neurological complications, Ramsay-Hunt syndrome, Bell's palsy, as I've shown in the previous slide, cardiovascular and cerebrovascular events. There is a 6 to 10% risk of recurrence in patients, and symptoms may be more severe and complications more frequent in immunocompromised patients. Herpetic or post-herpetic neuralgia, the shingles pain, it's one of the worst pains described, and on a scale of a survey done in people who had them, the acute pain is worse than labor pain in many people, worse than arthritis and even some cancer pain. It's very bad pain. Now, with this, you get lots of other social and emotional involvement that affects the quality of life of these patients. We already are focusing on the improvement in quality of life for our cardiovascular patients and heart failure patients. Having such an event significantly reduces the emotional functioning of patients, the cognitive functioning, social functioning, and physical functioning. Of course, it will affect their sleep, their work and career, and their daily activities. So, as I said, the good news is that this is preventable. We have something to offer our patients to prevent it from happening, which is the recombinant zoster vaccine. Let me touch a little bit on the efficacy and safety of this vaccine. I'm not going to go into the details of its manufacturing, not because I'm the expert in it, but it is an adjuvant system with recombinant subunit of non-live vaccine. It's a non-live vaccine. There were two main studies in it: the Zoe trials, the above 50 and the above 70 age group. 18 countries were involved. Yes, we as a country were not involved, and hope in future we get more on the studies and trial labs. It was a randomized, blind, placebo-controlled trial. It had more than 16,000 in the first trial, 14,000 in the other one. The endpoints were herpes zoster, post-herpetic neuralgia, and other complications, and it was a pool-specified analysis. Now, the recombinant zoster virus delivered 97% efficacy against shingles in patients above the age of 50. As you can see in the Zoe 50 trial, it maintained a 97% efficacy in these patients. In the above 70 age, it was a little less, but not too much. As you can see, it was still maintaining an efficacy above 91% in this age group, even above 80 years of age, which is very good. Even in patients who had pre-specified cardiac disease, whether they had hypertension, dyslipidemia, coronary artery disease, they maintained very good efficacy in these patients. And what is good about it is that the protection lasts for 11 years. So up to 11 years, overall efficacy of about 87.7% against shingles, which is very nice, and no safety concerns were found during the follow-ups. Of course, it's very important to have the two doses. There's a four-fold higher immunity when you receive both doses, and that's something that we need to stress on our patient. The second dose, after the first 3 to 6 months after the first dose, offers more immunity. So it's not only a single dose, it has to be two doses. As I said, the safety profile was very good. You do get the regular side pain and redness or swelling. You might get a little bit more myalgia and fatigue shortly after the vaccination, but no serious adverse events were recorded after the vaccine. And this is one of the things that we have to make sure that we relate to our patients that vaccinations are generally safe. Now, in the Zoe trial, participants reporting at least one of the 15 selected medical conditions, whether they had hypertension, lymphedema, or heart disease, no significant differences in severe adverse events, deaths, or potential immune-mediated diseases. So overall, very safe. In addition, and it's something that we are all also learning and we need to provide knowledge to our patients, is the co-administration with other vaccines. Many patients, our patients, as we said, in the guidelines are recommended to take influenza vaccine, coccal vaccines, other vaccines. It is safe to be co-administered with these um, uh, vaccinations, and it should be administered at different injection sites just for the local heritage. Guidelines, as you all know, many societies have been focusing on directing the healthcare professionals. Our Saudi Heart Association is one of them. We have been working on several guidelines and position statements in several topics recently, and very soon you will be seeing one on vaccinations and other patients with cardiovascular disease as well. But as you all know, the CDC recommended vaccines with shingles for patients above 50 years, and the Saudi MOH National Immunization Program recommendations of two doses, 2 months apart for adults 50 or older. The RZV is indicated for prevention of herpes zoster and post-herpetic neuralgia in patients 50 years of age or older and adults 18 years of age or older at increased risk, like immunocompromised. Now, it's very important. This is the USA as well. So it's very important to notice that, and this is something to stress, that the role of us as clinicians in promoting vaccinations for our patients is very crucial. As you all know, you all have patients, and how much our patients trust us and listen to us as primary care providers or care providers. And when they did a survey of patients' perception, only 25% had the acceptability of receiving the vaccine, but when their doctors recommended it, it rose up to 74%, which is 3 times the level. As I said, there is an ongoing position statement on adult vaccinations for patients with cardiovascular diseases, and we will be following our typical criteria for guidelines recommended, should be considered, may be considered, and contraindicated, and one of them very clearly will be recombinant zoster vaccine, and also the respiratory syncytial virus vaccine, which is the focus of our next talk. With that, I thank you very much. I hope it was clear and beneficial, and allow me to move to my colleague, Professor Kamal Al-Velayini, who will be talking about the second part of the talk. Now, we will be we're having discussion at the end. You are welcome to write your questions in the Q&A. We can take them as well. We will take and discuss it at the end. So Professor Kamal Al-Velayini will be talking about RSV, severe outcomes in older patients and comorbid patients. So please come.
Thank you very much, Professor Reed, for the introduction first, and definitely the presentation. Matter of fact, I just speak to my last patient about the vaccine and strongly recommend it. Probably he's going to have it tomorrow. And you're absolutely right. We do make a difference when it comes to recommendations, especially to our dear group of patients, our elderly. Now, if you allow me, okay, and we are on presentation module. Ah, okay, so Bismillah, salatu salam ala Rasulullah. Thank you very much for everybody to attend, and I'll be talking about the value of another vaccine hitting another virus, which is a highly contaminant virus, if I may say, to the same age group, which is the elderly vaccine, our elderly population. Now, RSV is a virus that can impact a lot of vulnerable population, like all adults, and this is the pivot or the corner of what we're talking today. So globally, RSV virus is a common contagious infection. It has moderate to severe lower respiratory tract infection. Now, it's highly contagious that co-circulates with other respiratory viruses. So the transmission can be either inhalation or contact with respiratory secretion from infected patients. And the common terminology that we learned in COVID is the RO. The RO is almost 3. So RSV is it's an RNA virus with 2 major and stable surface proteins. Now we have 2 subgroups. We have the RSV-A and RSV-B. And as you can see in this chart, the more you go with age, the death goes sky high. And this is from a US registry. And you can see that comparing less than 1 year and going up to 65 years, and you can see that the mortality among the patients who got infected with RSV virus is very, very high. And it's typically presented as an upper respiratory tract infection. It may progress into lower tract infection, just like all other viruses, especially RNA viruses. And it's cold-like symptoms. However, it leads to serious conditions. So when it hits the lower respiratory tract, we're talking about pneumonia, acute exacerbation of common comorbidities like asthma, COPD, or heart failure. It has a reported myocardial infarction or hospitalization goes sky high, including ICU admissions, and unfortunately, like I mentioned before, death. Now, the pathophysiology in the body, it's in 5 corners. It's either infection of nasopharyngeal or conjunctival mucosa. And then it binds to the cellular receptors. After that, it hosts the inflammation response. It starts the inflammation response at the host, and it's triggered. And then the lungs and the epithelial cell starts to get necrosed, leading to an airway obstruction, plugging, and the compliance of the lung goes down. And then we go to the further cardiovascular complication that can occur. So it's an escalation pattern of pathophysiology that starts very simply with a simple droplets and ends with a tragedy. Now, risk factors for severe RSV-associated disease is older age, especially more than 65, comorbidities. You're talking about people who already had been sick for a long time, and now then they become exposed for a serious infection, especially when there is asthma, COPD, heart failure, or coronary artery disease, and the common diseases that we have in our population, like diabetes and cardio and kidney disease. Now, weak immune system status that can happen by any modality, recent infection, probably some medication, poor dietary intake, poor quality of diets. There's a lot of modern ways of talking about weak immunity status, and it's 100% relevant. So combination with any of these three creates the big problem for that, including hospitalization, intensive care, and death. Now, it has a high burden disease. So again, in North American, Europe, and Asian Pacific region, we can find that there is around 5.2 million cases. Hospitalization is around 500,000, and this is almost 33,000. So in summary, after this part of the presentation, the actual burden of RSV virus in older adults is underestimated. So it is not considered in different diagnoses in adults. It contributes to the underestimation of the disease burden, and the combination of older age and comorbidities carries the complication and the continuous for 3 to 8 days carries a risk for weaker immunity in the targeted population. Now, again, RSV, but associated with other diseases. So adults with respiratory comorbidities are at increased risk for exacerbation. So COPD, they become almost 13 times increased risk, and they're more likely for hospitalization. Now, asthma patients are not as bad, and all this is coming from the US registries. It's more than 3.5%, 3.5 times more likely for hospitalization with RSV. Okay. What about cardiac conditions? So interplay between respiratory infection and cardiovascular disease, viral respiratory infection may exacerbate the existing, especially that almost all cardiac diseases, apart from maybe very few ones, are chronic. So chronic cardiovascular disease increase the risk of severe outcomes, and it's associated with complications like heart failure, ischemia, and infarction. Atrial fibrillation also can be added to the list. And the worst part which come is heart failure hospitalization, myocardial infarction hospitalization of any of the above mentioned, as I said, comorbidities. Now, inflammation. This is the key factor in a lot of our modern diseases that we're coming to understand more and more. And this is what's happening. The systemic inflammation due to the RSV triggers the pro-inflammatory cytokines. Now, these work inside the blood vessels, the coronary arteries, for say, and then you can see that it becomes like a microinflammation or a focus of inflammation. And when this comes on top of a previous plague, which we have a lot of them, unfortunately, then this plague becomes unstable due to the excess activation of different types of interleukins. And then we come with the cascade that we all know of thrombus formation, blockage, and myocardial infarction, and so on. So the trigger comes from inflammation to an already diseased vessels that will just stimulate the blockage. What about chronic heart disease? We can see that in old adults, it's much more in terms of hospitalization. Less than 65, okay, it's less than, but more than 65 is almost double the number. Now we're comparing non-heart failure to heart failure patients. And as you can see that regardless of the age or the condition, if you have a patient with heart failure, it's just sky high more than patient without. Now, for that part of the presentation, the summary would be that RSV can cause cardiovascular complication, clearly, and elderlies are with chronic heart failure and coronary heart disease are really in increased risk, and the survival really goes down with hospitalization, RSV, especially among with chronic cardiac diseases. Now, diagnosis, management, and prevention. Talking about very common symptoms, totally non-specific, that can come to any of us. And we really don't want to make a panic among our audience and our population. But at the same time, we really need to understand with them that taking care, preventing is the best. So there is no other, unfortunately, there is no other way to catch it and specify it that you come to a patient and tell them, oh, you have an RSV. That's quite difficult because everything is non-specific. So the best way is just to prevent it and prevent it and prevent it. What do we have here in our population in Saudi Arabia? MOH recommendation was based on a lot of recommendations, a lot of studies that came from the West and from the data that's coming from the registries, or I'm sorry, from the MOH registrations. And then we have RSV vaccine available at the ministry, at the primary healthcare all around, and it's becoming a recommendation in Arabic and in English. So what does the global guideline tell us is the recommendation is the first dose of vaccine that for patients with more than 60 years. Now, I need just to remind you that Dr. Walid mentioned the shingle vaccine is more than 50. Now, this is more than 60. And it comes from different association, the Global Intensive for Chronic Obstructive Lung Disease, the Global Initiative, the American Diabetes Association, and again, the ACIP recommendation also. So 60 for RSV, 50 for shingle virus. Again, we have another recommendation, and it mentioned that people above 75 standard immunization, people 60 to 47, they have an increased risk like diabetic and hypertensive. And that's why it's 60 in Saudi Arabia, because of the high percentage of comorbidities found on our population. And patients who have a severe manifestation of chronic disease with complication, again, residents of care facilities. Okay. Now, the positive profile is specifically called out in several paragraphs of the recommendation, like the vaccine efficacy and effectiveness. And you can see that in different paragraphs, it has a higher vaccine effectiveness, the effectiveness of RSV is related to later complications, and it's defined only available for that particular JSK vaccine. Only data on the JSK vaccine are available on the duration of protection. All right, let's talk about some advantages of the RSV vaccine that comes from GSK. Now, it's the only adjuvated RSV vaccine for older adults. It's a combination, and it's robust humoral and cellular immune response. And um, what is the indication on the label? It's indicated for active immunization for people for the prevention of lower respiratory tract infection and caused by respiratory syncytial virus RSV in adults 60 years of age and older, and in adults 50 to 59 years who are at increased risk of RSV, as I mentioned. Now, so of course, we will be, sorry. Of course, we will be looking at the efficacy and safety. So, ongoing phase 3 trial design is randomized placebo-controlled observer blind multicenter that challenge the placebo injection against the our vaccine mentioned today, and then it's almost 25,000 patients in 17 countries. Now, the primary endpoint of that study is to assist the efficacy of RSV vaccine in older adults in the prevention of the lower respiratory tract disease in adults more than 60 years. So the trial endpoints, primary endpoint, as we see, is efficacy. Key secondary endpoint is comorbidities, the efficacy against in people with more than one comorbidities, the safety, the recontagiosity, and the immunogenicity. And in a very heavy slide, we can see that among the two arms of the study, it's equally distributed in terms of age, almost sex, race, and so on. Now, what about the presence of cardiovascular comorbidities? Does it represent our real life? Well, it does, with more than cardiovascular comorbidities. The condition is equal when it comes to the both groups, the test groups or the placebo. So we do have COPD, asthma, chronic respiratory disease, and heart failure, equally distributed. Now, very high and consistent vaccine efficacy against severe RSV-associated disease and in older adults at increased risk. And you can see that the severe part is 94%, the pre-frail is 92%, 70 to 79 years, and so on, and so on, and so on. And this is all by confidence interval, showing a very high consistency of the vaccine. Now, does it help protect adults with comorbidities? It does, and it's tested, as we can see, the efficacy if there is one or more pre-existing comorbidity, and one or more cardiovascular comorbidity, or one or more endocrine metabolic comorbidities. And you can see that the percentage are quite high. So it is covering both, as I mentioned at the beginning, that we have two subgroups, A and B, and one dose for older adults produces durable vaccine efficacy against lower respiratory tract and severe disease. Now, it is the tolerability also was tested, and we can see that it is quite tolerable among the patients in the study. And the major thing was the general pain or malaise that people have with vaccines, very minimal erythema, and definitely very minimal swelling, and they were more or less very close to each other in the general complaints, but the malaise, fatigue were more in the vaccine. Actually, most probably you can tell if the patient is really having a vaccine or not. So, immunize with the only adjuvant RSV vaccine for your 60 plus patients, both for the study and for the MOH recommendation, the needed protection, the high and consistent efficacy, the one dose durability efficacy, and the safety that we've mentioned. With that, I conclude. Thank you very much, my dear audience and attendance colleagues, and thank you, Dr. Walid.
Thank you very much. Very nice and very interesting, thorough as well. يعطيك العافية. Now, may I ask you how the system works for you I know both of us work in both government and private. Um, who usually takes care of the vaccination in your system, in your clinics? Who follows it? Do you have a checklist for it? And then I'll tell you how I'm used to it at least.
Yes, we do have a vaccination clinic, an adult vaccination clinic. And what we do in my clinic is that we list patients for a regular referral to them upon the availability of the vaccine, and we keep doing that. So there is like a very close um, um communication with Dr. Maha Alawi. She's running that clinic. Now, this is in the university. And in my private practice, I immediately ask them to check with their closest مركز صحي, and they go there and they arrange for the vaccination of all types, and they put them in the record and they have it.
Sorry, I missed that. So excellent. Now, in as you said, in when I was in the university, we had a very structured heart failure program, and because we had already the nurse clinician and the pharmacist and the educator, and we had the storage place, we were able to store some of the influenza and pneumococcal vaccines at that time for our heart failure patients. But nevertheless, it's now expanding to the longer list, including the zoster vaccines, the RSV vaccine, the probably meningococcal vaccine, whatever vaccines. Um, I still believe, and this is the way I'm doing in my private practice. There is a vaccination clinic, and I insist on my patients to visit the clinic and receive all the recommended vaccines, and follow with them for that for two reasons. One is it assures the best care, uh, and second, they know better than me about these vaccines, about their storage, about which ones to do, the updated pneumococcal vaccine, the updated influenza vaccine, what is going on. So I still believe that it's a little too much for the cardiology clinic to take care of it. I've heard in those who have separate cardiac centers, some of the government or many MOH hospitals are isolated cardiac centers, and between them and the main hospital is actually distance. So they do have their own vaccination clinic there for their cardiac patients, and I think that's also a very good idea.
Also, you're 100% right. And adding to that, other reasons, like if the patient has a second dose, like in the Schengen, who's going to keep the record? And again, who's going to keep the record for side effects, reporting it? It's not just an injection that people just get and go. So it is a process that requires follow-up. Totally agree, Dr. Walid.
ممتاز. طبعا there was a question about if someone is already infected with shingles, can he receive the vaccine? Um, yes, but after 1 month of symptoms remission, after the symptoms have gone for a month, then you can receive the shingles vaccine. As we said, there is a chance of recurrence of the disease, so it still provides protection.
Dr. Walid, does this
تفضل.
justify that if a patient less than 50 years and he got the shingle, does this justify for him to receive the vaccine?
As we said, it's recommended for those above 80 and those 50, sorry, and those above 18 with higher risk. So if you have higher risk, whether it's because of immune compromise or probably increased comorbidities and things like that, and I think if you already had the disease, that by itself proves that you are at higher risk of the disease and the risk of developing it. Now, again, I don't think neither me or you are the experts in vaccinations, but this is from our asking and looking up. Now, yes, go ahead. Because one thing I was going to say is that the new recommendations now for the RSV is even above 50, not
Right.
even 60, especially those with higher risk. ال- uh, the other question that was here, can we co-administer both together, herpes zoster and respiratory syncytial virus vaccines together? Um, it- the recommendation is 1 month apart. However, MOH is recommending non-active vaccines to be taken at the same time, which is no problem because they are inactive, they are non-alive. But it's probably, let's say, the manufacturer or the company's recommendation is 1 month apart. Now, co-administering with influenza or pneumococcal is probably safer. One is asking, can one take shingles and RSV vaccine at the same time and day if one is 60 years old? That's what we said, preferably 1 month apart. So that's probably the repeated question. One is saying the nurse doing the vaccination. Yes, I mean, our nursing colleagues have been the ones leading the vaccination clinics. The doctor's role is probably putting the order, just following the track. But yes, having giving it and applying it and even looking at the records, and now in the presence of the records, it's Sahati. I think the our nursing colleagues do a great job in this. What else? No further questions. Now, let me ask you, Prof. Kamal. Um, it, the good thing now is that Ministry of Health is really supportive of this. Do you pass by sometimes of shortage in the hospitals of in vaccinations, and what's your recommendation for your patients at that time?
Um, I think the مراكز الصحية is very well equipped with vaccinations. They have this interconnection between each other. They will tell you, go there, it's available. So it's very they don't leave you they don't leave an open end for you. They once you're there, they'll find a way for you. Now in the university, we do have a very stable supply from the Ministry of Health for vaccines. But again, sometimes you feel you get a shortage, and it's up to the vaccination clinic. Sometimes they reschedule them. Sometimes they refer them to other hospitals or medical center. But the thing is, I think, Dr. Walid, what we were trying to emphasize here is the importance of our part in discussing this with our patients, recommending that, and finding the time for this in the visit, because there is a stigma on vaccines, as we know, after the corona vaccine. And whenever you say to anybody vaccine, he gets immediately defensive. But when our patients, they know people with shingles, they know how much they suffer, they know patients who died from pneumonia, their colleagues, their friends, because they're all elderly. So once they see they start understanding that what are we trying to prevent here, the defensive part starts to come down and they start to get convinced. And this is what we are meeting here about is that please think about this, put it on your schedule, put it on your checklist whenever you are facing patients with the mentioned criteria.
I agree. A checklist, as you said, is probably a very good way in remembering, and reminding us busy in the clinic. I do understand. As a cardiologist, you're looking at the compliance with his ARNIs, his beta blockers, the GLP-2 inhibitors. Is he really following instructions with diet and exercise? Is his weight changing? Is his blood pressure? We all live this, but if we have a checklist, either electronic or paper, to remind us of the things that we really need to follow with patients, we'll remember it very well and discuss it. I have a question here. I have the answer, but I will ask you because we'll see. I mean, is the RSV virus allowed to be given in dialysis patients?
And sorry?
Dialysis patients, renal patients, dialysis.
Oh, it's number one. I mean, these are very, very highly fragile patients, and they definitely need it as a routine. Definitely.
Excellent. Yeah, it is. It is part of the recommendations of MOH recommended renal centers, and it's recommended to be given before the dialysis session. Because the patient deserves both. As we said, if they keep on saying, if we keep people keep on asking if we can give both. Yes, you can give both shingles and RSV vaccines, preferably a month apart. It is recommended. Uh, why people fear of taking vaccines? Is there really any? Now, why do people fear of taking statins? Why do people fear of taking blood pressure medications? Why do people fear of taking vaccines? Why do people fear? I think we are under scrutinized, bombarded with social media, misinformation. Unfortunately, people say a lot of things. They keep on blaming most of our medications and vaccinations for a lot of diseases. Although you can really be comfortable with the studies. We have lots of randomized controlled trials in many aspects, whether it's vaccinations or medications, showing the safety of these therapies, and the harm is negligible, if even there. Vaccinations as well. So I think the misinformation that we are getting from the media, and unfortunately sometimes supported by colleagues in the healthcare, really make people worried. But I do advise always take your information from the authorities, from the real فاسألوا أهل الذكر, from the Ministry of Health, from the societies, from the healthcare professionals, from the universities. Take your information from the right sources so you avoid being misinformed. You want to add to that, Dr. Kamal? Dr. Kamal?
هلا هلا تفضل.
Anything to add at the end? I think we reached the
Oh,
end
to
of
add,
the
I'm sorry,
session.
I
Yeah,
didn't hear that. Sorry.
yeah.
I'm just re-emphasizing a slide that Dr. Walid, you mentioned about the level of pain. And we're being doctors just to avoid people from having suffering. So now we have a tool. The tool has been tested and highly justified. we are seeing now a lot of shingles. Yani we are not in the infection disease area, but we are physicians who are seeing patients, and now they are becoming more and more and more. I have no explanation for that, but I have a very good tool to prevent that. So please, my dear colleagues, let's be positive in that, spread the word, support people to go to the experts and consult them, see if they are suitable for them, hear more about it before shutting this very, very rahma door. Thank you very much, Dr. Woody.
Thank you. Prevention is the best cure. At the end, I do thank you all for being with us tonight. MashaAllah, the attendance is excellent. I thank Prof. Kamal for the very nice presentation and discussion. It was very enlightening, I think, for all of us. I personally learned a lot from it. And looking forward to have you in future events and see you in person. Have a good night. Assalamu alaikum.
السلام عليكم.
Uh,